So really where we're going to transition to now, it is focusing on the impact of stress and stress-related processes that can result in fatigue and low energy. Now, as a clinical psychologist, I will often see what I'm trying to help people with is getting them to identify maladaptive patterns of thought, emotion, and behavior. And that the skills in terms of reflection and clarifying what my feelings are and repairing or managing those feelings and a variety of different kind of coping skills. In a sense, we're trying to get people to spend more time in their prefrontal cortex, to be able to kind of look at, assess, evaluate, and decide in a more intentional way. And a lot of these skills would fall under the umbrella term social or emotional intelligence, right? And the reason why all of this is relevant, I want to make sure I continue to connect the dots, is because it's not so much the feelings that are going to create the problems. It's prolonged distress that results from the events in our lives that can actually lead to vascular inflammation and other inflammatory processes that will then wear out the body, depleted of energy, and result in fatigue. To show you kind of the importance of the choices that we make early in our response to stress, RCBF stands for Regional Cerebral Blood Flow Studies. And basically, these studies bring people into the lab and they stress them out in a variety of different ways, 30, 40, 60 minutes worth of stress. And they randomly assign them to two different groups. One group is told to just sit there and take it. The other group is told to give voice to your feelings. Talk about what's going on. Just kind of label the thoughts, the reactions you have. In a sense, intellectualize your experience. Don't just kind of immerse yourself in it, but rather be able to label, identify it, and express it. And it turns out that it's that second group who has substantially lower activation of their amygdala within moments. Now, lowering your amygdala activation, you're likely to see less reactive behavior, okay? Less even hostile or aggressive behavior. But it's just one example of how what we choose to focus on, how we choose to respond to the same stressful event can dictate how our brain activity is going to be modified, and as a result of that, then the cascade of events that can occur. Now that cascade, the hypothalamic pituitary adrenal axis, the HPA axis, the fight or flight response. In a nutshell, what happens is that we perceive something as threatening, something that requires us, we believe, that needs changing. Our hypothalamus then is activated and it results in the release of corticotropin releasing hormone, CRH. Among other things, CRH is going to upregulate your pituitary. When you have an active pituitary, what do you get but an elevation in beta endorphins and adrenocorticotropin hormone, or ACTH. Among other things, ACTH will upregulate the adrenal gland, and what happens then, but an abundance of cortisol and glucocorticoids are apparent in the system. Now, when we want to quantify how much a human being is experiencing stress, physiologically speaking, we rarely, if ever, go farther upstream than to measure your cortisol or glucocorticoid levels, because those are the two substances that have the most diverse negative consequences if they're elevated. Now, in the short run, they're actually providing, if you will, good services. Cortisol, in the short run, improves cardiac tone. Cortisol, in the short run, increases visual acuity. But in the long run, elevated cortisol can lead to neuronal death in the hippocampus, poorer short-term memory, difficulty concentrating. Elevations of glucocorticoids chronically, absolutely can suppress your immune system. Now, this whole process, this whole cascade of events really is wonderfully self-regulating. That is, I kept kind of emphasizing, among other things, each of these elements, whether it be CRH or ACTH, will stimulate sympathetic nervous system arousal, but within moments it will often do something else, kind of down a different tributary of the stream, that will result in a downregulation of the system, a parasympathetic response. So if it tends to be in such wonderful balance, why is it that we so often now associate stress with bad outcomes, not good outcomes? Well, it's because the stressors we experienced in 2012 aren't really the ones that were kind of designed for our body to take. Our body is built for survival, first and foremost, right? And so, in fact, you know, a lot of us have seen that Hans Selye, that graph that shows the fight or flight response. You see a response, you have sympathetic nervous system arousal, you're activated, and then there's the recovery or relaxation phase after the stressor is over, right? That's not how it happens in 2012. In fact, I will tell you that you're probably wasting your time if you're trying to modify the first half of that response. All the value of really what we have to offer our patients and clients is actually to deliberately have them engage in the second half of that response. Instead of this phasic kind of curvilinear relationship, I want you to think of stress much more as a staircase. Because we go from one stress to the next, to the next, to the next throughout our day. Right? I mean, your own example. You wake up this morning, your alarm clock went off, and you go, oh, another day at work. Oh, wait a minute, I'm going to that seminar. Where is that seminar? Okay. Where's the brochure that tells me where that seminar is, right? And then it's like, oh gosh, I still need to get the kids off, pack their lunch. Did I tell everybody at work that I'm not going to be at work today, right? What appointments have been adequately canceled, warnings of meetings I won't be attending, and so forth. And we keep going throughout our day on a staircase, up and up and up and up. So really there's a phrase that you'll hear me say a couple times this afternoon, and it's one that I really use a lot in helping patients understand what's going to be beneficial in terms of managing stress. You want to have separation between the stressors. So again, it's not, and we're not going to be very effective at trying to moderate or modify the first half of the response, but rather than have them stay there and then think about the next stressor that they have to deal with, have them get some separation before they will go up again. Okay? Very critical kind of transition of how we think about stress, helping our patients manage stress in terms of coping skills. Now, managing stress is going to be kind of more difficult for some people than for others. Now, you know, all of us have been exposed to the term type A behavior or type A personality. And back what I refer to as the ancient history, back in the 1970s. Howard Friedman and others kind of shared with us this hurry sickness, this tendency to always be in a rush, kind of multitasking, all things, you know, my calendar is totally full all the time. That kind of person was at increased risk of developing cardiovascular disease. And it was true that your score on a type A behavior questionnaire did correlate with all these risk factors for developing cardiovascular disease. But within about 6 or 7 years of those original studies, the correlation between type A behavior and cardiovascular disease risk went down to single digits. Now, a correlation of 0.06, 0.07, you know, I can get that published. I just need enough subjects, a couple hundred subjects, and that will be significant. But as a clinician, I'm fairly unimpressed with a correlation of 0.07, right? Fortunately, what came from these original studies is now the #1 psychological factor that causes cardiovascular disease. As a researcher, I will rarely use that word, causes. But what's the psychological trait that causes cardiovascular disease? Cynical hostility. It's not being in a rush, it's having an attitude of dog eat dog world. Every man and woman for himself, right? It's always a zero-sum game. That win-win stuff, oh, that's garbage, that's baloney. You know, there's always going to be winners, always going to be losers. And for heaven's sakes, I'm going to be a winner, right? In fact, even if I have to cheat to make sure I win, that's how important this competition is, right? And in fact, if you beat me, if you win, I don't really trust that you didn't cheat too to get ahead. So I have a cynical mistrust of other people's motives. Now, what this slide is showing is 5 different longitudinal cohort studies. And I could show 4 or 5 others in addition. Each of these are looking at 5, 10, 20,000 people. In aggregate, we have data from over 250,000 people who have been followed for an average of 35 to 40 years. And remember, OR stands for odds ratio. What does this show us? That if you were in any of these studies, and basically in these studies, we're giving hostility, anger questionnaires. You didn't need to score in the top 2%. You didn't need to have some anger, hostile pathology. You just needed to be in the top 50% of the 10,000 people in this study, and you were anywhere from 2.5 to more than 4 times as likely to be diagnosed with cardiovascular disease before your 70th birthday. Now let me clarify, IED in the Collaborative Psychiatric Epidemiologic Survey out of the San Francisco Bay Area, IED does not stand for improvised explosive device. It actually stands for intermittent explosive disorder. It's the only study of its kind that took such an extreme measure of hostility rather than just a Cook medley or some other 20-item questionnaire measuring anger. But again, 2.5 to 4 times more likely to be diagnosed what we consider to be an early age of diagnosing cardiovascular disease before your 70th birthday. Now, if I replace the word anger with the word anxiety, those odds ratios are about cut in half. Usually what you're going to see is between 1.5 to 2.5 times more likely, not if you're diagnosed with OCD, panic disorder, generalized anxiety disorder, or anything like that, or the top 10% of the scores, just in the top half of the 10,000 people who filled out the questionnaire. If you were in that top half of scores, you were usually about 2.5 times more likely to be diagnosed with cardiovascular disease before your 70s. And finally, we replace the word with depression. Now, the odds ratios go down to about 1.5, maybe 2. So this is not, again, diagnosed depression. This is simply the top 50% of some scale we gave you 30 years ago predicts you're maybe 40 to 80% more likely to be diagnosed with this disease, coronary artery disease, before your 70th birthday. Now, what's fascinating is while cynical hostility is the runaway winner in predicting the onset of disease, anxiety and depression, kind of a distant second and third, the order of those 3 psychological variables completely reverses when you're looking at once a person has been diagnosed with disease, how fast will that disease progress? Now, depression is your #1 factor. The kind of typical, a normal response to, being in the hospital and having a bypass surgery or having a stent placed in your chest is to be somewhat depressed. And for 30, 60 days out, that's kind of the average response. However, if by any means, whether it be the cardiac rehab team or some other way, you didn't have those feelings of depression resolved, you're then risking like twice as likely to be readmitted to the hospital for cardiovascular complications if within 6 months you don't have those depressive symptoms resolved. Compared to people who were initially depressed but then, if you will, recovered, those who never recover and 6 months later remain elevated on scales of depression are taking twice as much medication 2 years out. So again, the psychological factors play a very significant role, but sometimes in some nuanced ways. Now, this anger, this hostility, stress is going to play, again, more of a role for some people than for others. The study is looking at blood pressure. because when we're stressed, when we're annoyed, irritated, our blood pressure goes up. But in the studies where we bring people in and stress them out, if you have no family history of hypertension, your blood pressure goes up, and usually within about 8, maybe 9 or 10 minutes, it goes back to baseline. However, if you have a positive family history of hypertension, your blood pressure actually doesn't go up any higher in response to stress, but it takes longer to recover, 12, 14, 15 minutes or more. It's the area under the curve of recovery that drives the clinical condition. I'm going to say that again because that's pretty important. It's not the initial reaction or spike in response that is most correlated with developing disease. It's the area under the curve of recovery that drives the clinical condition.